All right, and I'm delighted to introduce our incredible panel today. Dr. Kara Bischoff is the Associate Division Chief for Outpatient Palliative Care and the Medical Director of the Outpatient Palliative Care Service at the University of California, San Francisco. Dr. Bischoff has developed a particular expertise in palliative care for people with ALS. She's published substantially about outpatient palliative care for people with illnesses other than cancer and was recognized as an emerging leader in palliative medicine by the American Association of Hospice and Palliative Medicine. Dr. Bischoff received her medical degree from Harvard Medical School, followed by a residency and chief residency at UCSF in internal medicine and a fellowship in hospice and palliative medicine also at UCSF. She's an active member of the American Academy of Hospice and Palliative Medicine and the International Neuropalliative Care Society. She is a mother, an outdoor enthusiast, and a San Francisco Bay Area native. Next, we have the wonderful Robert Lemons. Robert is a retired manager, distribution operation at the U.S. Postal Service, DFW Airport Mail Facility. He was a registered X-ray technician and has a Bachelor of Science degree in biology. He and his late wife, Susan, had 5 children together, and they were very helpful during Susan's fight with ALS. He doesn't know if he could have made it sometimes without their help. Robert promised his wife that he would continue working with the ALS Association and other ALS organizations in all ways possible to bring awareness about ALS and to help make ALS livable. He also promised to share what they learned about taking care of a person living with ALS with others. He kept their accessible van in Susan's power wheelchair, which he uses to transport ALS patients that do not have transportation to doctor's appointments at an ALS clinic. This was a request from his wife 3 months before she passed. Last but certainly not least, we have Harry Grecousis, who is a retired USPS data programmer, and Bonnie Decker, who is Harry's wife and primary caregiver. Harry started experiencing weight loss, fatigue, and breathing issues in September 2018. While undergoing outpatient medical tests, he was hospitalized in March 2019 with acute respiratory failure. He required emergency intubation. The following week, he was diagnosed with respiratory onset ALS. Once home, Harry's treatment continued to include outpatient care whenever possible, managing the symptoms of respiratory failure and striving for his best quality of life. This has meant combining follow-up care with UCSF's ALS Neurology Clinic and UCSF's outpatient palliative care services with Dr. Bischoff and her team. Despite his original poor prognosis, Harry continues to keep a very active social life. Bonnie and Harry both believe his decision to incorporate palliative care services into his ALS treatment journey has been a big part of him meeting his goals. Thank you so much to Harry and Bonnie, to Robert and Dr. Bischoff for being a part of this incredible panel and for volunteering your time today. Now I'd like to turn it over to Dr. Bischoff for her presentation.
Thank you for that very kind introduction, Aditi, and thank you to everyone who's here and spending some time out of your day to learn a little bit about palliative care for people with ALS. I'm going to have a brief presentation, but I really hope this can be primarily a conversation. So I welcome questions anytime. Please feel free to interrupt me. And with that, I'm going to share my screen and start my slides. So living fully, living well. Palliative care for ALS. I wanted to acknowledge one of my colleagues, Umbreen Mehta from Johns Hopkins, as well as our entire INPCS Palliative Care for ALS working group, as they've helped put these slides together. And Umbreen is actually off work right now, as she just had her first child. So as a matter of disclosures, I have some grant funding from the ALS Association to study palliative care for ALS. So what is palliative care? In a phrase, it is care focused on improving quality of life for people living with a serious illness. That's my one sentence version that I use. It can be provided alongside life-prolonging treatments, including ALS care, at any stage of the illness. And I think about palliative care as having 3 buckets. We focus on symptom management, This can be management of physical symptoms like pain, shortness of breath, difficulty sleeping, constipation, etc., as well as mood symptoms like depressed or anxious mood, which can be so common. The second big bucket of what we do is care planning, making sure that people understand their illness and what to expect in the future and have the time and space to think about what matters most to them, what are they hoping for, and what are they worried about, so they can make decisions about their care that make sense for them as a unique individual. And the third big bucket is support, support to people living with an illness and to their loved ones, realizing that a serious illness can affect everyone in the family in different ways. To say a little bit more about this, oops, my slides are not wanting to advance. Palliative care is very much multidisciplinary team care. At UCSF's Palliative Care Clinic, we have physicians, as well as a nurse, social workers, and spiritual care providers who work together because we realize that a serious illness often involves medical aspects, but also very much mood, psychosocial, spiritual, existential, and practical aspects. And so we have different members of our team that focus on each of these areas. In palliative care, we are an extra space and dedicated attention to symptoms. Not that the ALS team doesn't also focus on symptoms, but sometimes, especially when symptoms have been difficult to manage, it can be helpful to have that extra time and space and that dedicated focus on symptoms. Additional time and staffing for support, so emotional support, realizing that it can be a really profound experience to go through a serious illness. It can bring up a lot of intense emotions, fears, and questions about the future. And we try to give a little bit of time and space for those important issues that don't always have adequate time in other medical visits. We're trained in serious illness communication. We try to put some extra focus in care coordination, realizing that we have a nutty healthcare system that we're all trying to navigate. And many times people need a little extra guidance to help with that navigation. And we help provide a transition to end-of-life care, including hospice care when that time comes. The benefits of palliative care are numerous, as demonstrated in the literature. It's been shown to help people live better, and in some contexts, also longer. The dedicated time and space to address symptoms, distress, and quality of life have also been demonstrated in the literature. We try to ensure that treatments are consistent with people's values and priorities, and to help coordinate care. So to just tell you a little bit about some of the research that's been done about palliative care for ALS, there is a randomized controlled trial, which is sort of our highest quality evidence, done in Italy of palliative care for people with neurologic illnesses, including people with ALS, that showed an improvement in pain, shortness of breath, bowel symptoms like constipation, and sleep with palliative care by 16 weeks of follow-up. There is a subsequent and larger randomized controlled trial of palliative care for people with neurologic illnesses, again, including but not only people with ALS, done in the UK. And this showed improved symptoms and satisfaction with care when palliative care was integrated alongside neurologic care. There have been a number of studies in the US, including a cohort study we did at University of California, San Francisco, that showed that with palliative care, we can help address needs in multiple domains, including physical symptoms, psychosocial and spiritual concerns. We help people engage in and complete advanced care planning documentation, and we help address care partner needs. With palliative care, we showed that people's rates of advanced care planning documentation increased, and use of hospice was common. At other centers in the United States, they've also shown that integrating a palliative care physician into the ALS team can help with physical and mood symptoms and support people around the decisions they face about their care. So I'm going to try to bring this to life with a case. Mr. R is a 59-year-old man who loves to run. And one day he had a near fall while running and then developed low back pain that persisted. He didn't think much of it, but over the following few months, he began to feel less stable on his feet and he was no longer able to run. He had an evaluation with a spine specialist, which is a common story we hear, about 6 months later, and was treated with an anti-inflammatory injection in his low back. But unfortunately, his weakness continued to progress. He was ultimately referred to see neurology about 1 year after his first fall and the onset of his symptoms. And they found that in addition to his limb weakness, he had lost weight. It took him longer to chew and swallow. He had mild shortness of breath at night and associated anxiety. He was diagnosed at that visit with limb onset ALS. So it's really common that we hear stories like this, and it's really true that we find that people living with ALS have a lot of needs in different areas. And I'm sure I don't have to do much to convince you of this. There's often a high symptom burden, both physical and emotional symptoms. There are communication challenges, which can have a really profound impact on quality of life. There's a protracted stepwise decline over time, which is particularly difficult. There's uncertainty about the future. There are a lot of complex decisions to make, including about feeding tubes and breathing machines, for example. And there are high caregiving needs. So in palliative care, we really strive to alleviate symptoms and improve comfort whenever possible, try to enhance emotional and psychological well-being in ways we can. We try to facilitate communication to help people make decisions about their care and certainly support patients and families throughout the journey. So a quick question for you to make sure you're all awake and still with me. Truth or myth? People must stop seeing their ALS team if they're receiving palliative care. Feel free to unmute if you'd like to
False.
pose. False. Anyone
False.
else? Another false. Yep, that's exactly right. It is false. Palliative care, as I mentioned on one of my first slides, can be provided alongside other types of disease-modifying or life-prolonging treatments, including ALS care. So absolutely, when you're accepting palliative care, you're not giving anything up. You can still get the ALS care. Truth or myth? People cannot continue ALS treatments when receiving palliative care.
That should also be false.
You're right, exactly. So similar to my last response, when people are receiving palliative care, they can also receive disease-modifying treatments, treatments for their ALS. It's different than hospice in that way. And so I think sometimes people think of palliative care as being purely comfort-focused treatment. But that's not always the case. Many people who are receiving palliative care actually want to treat their illness as aggressively as possible, want all disease-prolonging treatments that might include going to the hospital if they were to develop an infection, even going to the ICU, being put on a breathing machine, for example. All of these care choices can be consistent with palliative care. So previously, sort of the old way of thinking about was that people would receive disease-directed care, in this case, ALS care for the majority of their illness, and then palliative care would come in and ramp up as people approach the end of their life, and then they would transition to hospice care. But our newer model, certainly over the past decade or so, becoming increasingly common, is that palliative care can be provided from the time of diagnosis and alongside disease-directed ALS care throughout the illness, generally ramping up over time and often transitioning to hospice and then bereavement care. So to come back to our case, Mr. R continued to struggle with his breathing and associated anxiety. He was started on BiPAP, which is a breathing support machine that helped his breathing and his energy significantly. He was also started on a low-dose opioid, which we think of as pain medicines, but can also be helpful when shortness of breath becomes severe. He was using this as needed for severe episodes of shortness of breath. And he was started on anti-anxiety medicines by the palliative care team. Additionally, he met with the palliative care social worker for counseling. The social worker also met with members of the family for support around adjusting to their caregiving role. So just a little example of how the palliative care team alongside the ALS team can help with both physical and emotional symptoms, both through medication adjustments and in non-pharmacologic ways. By a year and a half after his fall, he was losing weight and his ALS team recommended a feeding tube. However, he felt very unsure, not confident that this was the right choice for him. So there's a lot of complex decisions in ALS. Again, I don't have to convince you of this, I'm sure, but many people face a decision about feeding tubes, about whether to try invasive ventilation, meaning ventilation through a tracheostomy, whether to have resuscitation if their heart were to stop, and how to address communication challenges. So the palliative care team tries to assist with advanced care planning in ALS. Some of the questions that we commonly ask are, as you look to the future, what are you hoping for? Trying to understand people's values, priorities, what's feeling most important to them in light of their illness and how they're hoping things will go. A question I often pair with that is, as you look to the future, what are you worried about? Again, just trying to understand people as the complex individuals they are and try to address what feels most important or what's weighing on them. We also commonly ask, if you weren't able to make or communicate your own healthcare decisions, is there someone who you would trust to speak on your behalf? This person would be called a durable power of attorney for healthcare or a surrogate decision maker, sometimes abbreviated surrogate. And it's really important, especially for people with ALS who may lose their ability to communicate their preferences for medical care. If no one is named, decisions are typically deferred to a default surrogate. So in some states, there's a legal hierarchy in who the medical team should defer to when a patient can't make decisions for themselves. But in the state of California, there's actually no single legal hierarchy, and instead the medical teams turn to whoever seems to be closest to the patient, have their best interests at heart, to help them make the decisions. But that may or may not be who the person with the illness wants to make decisions for them. So it's really important to clarify this. A surrogate decision maker can be documented in an advance directive document. This is a legal document to designate a surrogate and specific preferences for end-of-life care. It doesn't have to be completed by an attorney, although many people do complete it with an attorney as part of creating a trust. But we in the palliative care team also commonly encourage these and talk through these with people. It can be updated at any time as well. We really try to emphasize that and try to encourage people to revisit it if their health has changed significantly to make sure it still reflects their current wishes. And it's different from a post form, which is another really important advanced care planning document that stands for Physician's Orders for Life-Sustaining Treatment. It's a standard one-page form that's in the state of California and many other states, but not all states. And that's an active order for what kind of medical care you would want at this moment in time. Whereas an advance directive is talking about what kind of medical care you would want in a future situation if you are seriously ill and unlikely to improve. So they're both useful and they have slightly different applications. We also sometimes refer people to a website called Prepare for Your Care, found at prepareforyourcare.org. It's a really great website that walks people through all the steps in advanced care planning and creating an advance directive. Nice option if you'd like to take a look at that. Additional aspects of advanced care planning that we commonly engage people in is thinking about their upcoming treatment options, which may include a feeding tube, a ventilator, resuscitation, hospitalizations, for example, and try to make recommendations for people that are rooted in their values and priorities, and allow additional time in our visits to explore these options and get questions answered. I think certainly the ALS team often also discusses feeding tubes, ventilators, and other things, but sometimes people feel undecided, ambivalent, or that these are complex decisions and they benefit from a little more time and space and a neutral team to discuss these with. We also frequently talk to people at some point in the illness about whether and when a transition to hospice may be wanted. So to talk a little bit more about hospice care in ALS, this is a program and an insurance benefit that is appropriate for people with a prognosis of less than 6 months. So hospice care is different than palliative care in that way, in that palliative care can be provided at any point in a serious illness, whereas hospice care is specifically for people with a prognosis of less than 6 months. And in order to be referred to hospice, you have to have your doctor on the referral order say, I do think it's likely that this person's prognosis is less than 6 months. Of course, we are sometimes wrong about that, but that is one of the requirements for referral to hospice. And hospice care is really focused on providing comfort over life prolongation. So, unlike palliative care, which can be provided to people with all different goals, whether your goals are life prolongation over everything else or comfort, hospice care is really for people who've reached a point in their illness where they want to prioritize comfort over life prolonging treatments. So, when is it time for hospice? When prognosis is most likely less than 6 months, so advanced respiratory weakness, significant weight loss, other life-threatening complications like a hospitalization for a pneumonia, might be some of the things that would indicate that you may qualify for hospice. And a person has to prefer to focus on comfort and staying at home rather than going back to the hospital should something happen, such as a fever or pneumonia, for example. So truth or myth, people cannot continue ALS medications in hospice.
Oh, well,
False.
I say false.
False?
Well, it depends on the medication. Because it's a lot to do with cost, I would say.
You're right, actually.
True.
You're right. Yes. So hospice is a program where they're paid a flat amount per day, and it's about $158 a day. It's not a lot of money. And unfortunately, there's a lot of treatments that they can't provide when people are on hospice. Also, as I mentioned in a couple slides ago, the hospice philosophy is about providing comfort in the face of a serious and terminal illness and pursuing comfort over life-prolonging treatments. So in general, life-prolonging treatments, including ALS medications, are not provided while on hospice. That's certainly the case with Radicava, for example, but Riluzole, which is a cheaper medication, can sometimes be continued. Truth or myth? Sorry, did I skip a slide? I think I did. So what to expect when on hospice? Certainly, you can expect attentive symptom management. Typically, the hospice nurse would come to the home and check on symptoms and try to help address symptoms, titrating medicines as needed. Roughly once a week, can be more often, can be less often as needed. Easier access to symptom medications, medical supplies, and equipment. They generally will deliver medications pretty quickly and make it a little bit easier to get access to a lot of types of basic medical equipment, like a hospital bed, a bedside commode, for example. They can do home visits, including after hours. They have a team on call 24/7, so you can call them in the middle of the night if something comes up. For people with ALS, they generally will continue tube feeds and BiPAP as respiratory support because those are thought to help promote comfort, which is a primary focus of of hospice care. They also provide a lot of care partner support with more touch points at home. And the program comes with grief support for up to a year after the death of a person with an illness. But what not to expect, no member of the hospice team comes out and provides 24-hour direct personal care in the home. Unfortunately, I think that's a common point of disappointment. That type of direct hands-on care still has to be hired out of pocket if it can't be provided by family. They also generally don't provide medications for ALS aimed at prolonging life, such as Radicava. They don't do blood work and imaging. If you were to develop a fever, for example, they don't do that kind of workup. Instead, they evaluate people clinically and see sort of what are their symptoms, and based on that, how can we best treat with the goal of promoting comfort and keeping people at home. Hospice teams generally don't provide rehabilitation services like physical therapy or occupational therapy. This is also sometimes a point of disappointment for people with ALS, but fits with the sort of hospice philosophy of promoting comfort and not necessarily having an expectation that people can improve. And they also can't provide really expensive equipment like new power wheelchairs, or speech generating device, or non-invasive ventilators. So these are types of equipment that we often encourage people to try to obtain before they start on hospice if they need them. Generally, the hospice team will try to keep people at home and avoid further hospitalizations unless they're absolutely needed to promote comfort. So truth or myth, people must change their code status to do not resuscitate to enroll in hospice.
False.
False. You're right, it is false. This can be a little surprising for people. Many people think that they'd have to be do not resuscitate, but some people have a strong desire to have a resuscitation attempt, even at the end of their life when it's not likely to be successful, and you still can request a resuscitation attempt if you're on hospice and feel strongly about it, though most people on hospice certainly are do not resuscitate. Truth or myth, all people move into a hospice facility when they enroll in hospice?
False.
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 Correct. False. Most people receive hospice care at home. Certainly that's true among people with ALS, much more common. So where do you go for hospice care? Wherever you call home. So most people are at their private home, but others receive hospice care in a nursing home, assisted living, or other facility where they're staying. A few resources that I wanted to make you aware of. The ALS Association put together a brief 10-point cheat sheet about understanding palliative care. There are a number of other resources here. The INPCS is the International Neuropalliative Care Society, which if you're interested in getting involved in this area, joining our Palliative Care for ALS working group, for example, you can certainly learn more there. And how to get palliative care. It is a medical specialty like, cardiology or gastroenterology, so it does require a doctor's referral, and you can ask any doctor for a referral to a palliative care team. You could ask your ALS doctor or a primary care doctor, for example. It is like other medical specialties, generally covered by insurance with a typical copay. Palliative care can be delivered in clinic, at home, or by video. So there's two main flavors of palliative care, either clinic-based palliative care, a lot of which is happening by video these days. Certainly that's the case for our care at UCSF, and home-based palliative care. And I think you'll hear about both of these examples from our other panelists today. They're each a bit unique. I'm happy to expound upon that in the Q&A. And palliative care visit frequency is typically matched to people's needs. So we might start by seeing people roughly every 3 months, maybe a little bit more or less than that. And it often ramps up if needs increase and people need more support, either help with a symptom or help with making a decision or just general support. So how palliative care complements ALS care, if I were to summarize this in a slide, the ALS team focuses a lot on the diagnosis, education about the illness. They may engage in genetic testing, help people understand their risk factors. They track the illness over time and try to help people understand what to expect, therefore. They talk to people about disease-modifying treatments as well as medication, both medications and equipment that can help. They do frequently touch on symptom management and support, including connecting people with community resources. But in palliative care, there's a little bit more bandwidth to focus on the physical and mood symptoms because we're not focused as much on the disease management and monitoring, to provide emotional support and try to promote healthy coping in the face of what is undoubtedly a really difficult illness. We spend extra time on advanced care planning and trying to help prepare people for the future. Not that that's altogether unique, because the ALS team is doing that too, I realize. We provide additional time and space to consider one's treatment options, to support family members or caregivers. And we often talk to people about their options for including hospice and other types of end-of-life care when the time comes. So I hope that was helpful to you. I'm going to stop, leaving plenty of time for the next portions of the panel presentation and for questions.
Thank you so much, Dr. Bischoff. We have one question in chat. Hospice doesn't accept ventilator patients, correct?
Great question. Generally not. Most hospice teams don't have a lot of experience with managing ventilators. There can be exceptions. Certainly there's some hospice teams that are more comfortable with that, or if the ventilator is going to stay at a stable settings and not be escalated, that might be something that they're comfortable with. But generally the hospice team doesn't have a respiratory therapist, so they don't have all the same, skills and expertise that an ALS team, for example, would have. So it is uncommon for hospice teams to take care of people on ventilators, but not entirely unheard of.
Can I
But
send?
they will accept you, right? They will accept you at a hospice facility if it's a life-sustaining, like a non-invasive ventilator.
So non-invasive ventilator, yeah, so generally regarding, I was a moment ago speaking about intubation via a tracheostomy, which hospice teams are generally less comfortable with. But regarding non-invasive ventilators, so there's BiPAP, and which are sort of slightly simpler machines, and then there's non-invasive ventilators, which are more complex machines and to be noisier, you may have noticed, and have more settings. And generally, hospice teams will try to shift people towards BiPAP rather than non-invasive ventilators. I have successfully advocated for people to be able to keep their non-invasive ventilators in certain situations where I've said they really need this for comfort. They've tried a BiPAP and it didn't provide adequate support to manage their shortness of breath, but it's rare. Most often a hospice team will try to use a BiPAP machine rather than a non-invasive ventilator.
But
And
they
that
will
can be
admit you to the facility if the patient is on a non-invasive volume ventilator. My wife was admitted, but I managed it.
got it. And the facility, it was a hospice facility?
Yes.
Yeah, a residential hospice facility. Yeah. So those kinds of facilities are kind of an uncommon place to get hospice care, but there's some of them. Here in the Bay Area, we have a few small residential hospice facilities that have like 6 beds. There's several of them, but most people receive hospice care at home. So it's great that they would admit her to that facility. And that doesn't surprise me that they didn't feel comfortable managing the machine, but they were okay with you managing it.
Yeah, and in my situation or my wife's situation, we did everything at home. Hospice was at home,
Mhm.
but towards the end, I couldn't manage the phlegm that was
Mhm.
building up in her throat and her chest, her lungs. So that's when I decided to take her to the hospice facility
Mhm.
for the
Yeah.
last couple days.
Yeah. And I'm sorry for my cagey answer, but it does depend on the hospice agency in terms of whether they will accept a non-invasive ventilator, whether or only support people who are on BiPAP. It's an unfortunate thing, and it's sort of a situation that's very unique to people with ALS. But we do try to advocate for the non-invasive ventilator when that's really important to manage someone's shortness of breath.
Thank you.
Yeah.
We have another question in chat. Does palliative care company prescribe strong pain medications or only ALS doctor prescribes?
Yeah, so I would expect a palliative care doctor to prescribe strong pain medicines and to feel more comfortable doing that than an ALS doctor. Certainly at UCSF, that's how it works, that the ALS team defers pain management to the palliative care team that does have more training and experience in it, typically.
Thank you. Another question, how do you get a referral for palliative care?
Yeah. So palliative care is medical specialty, and it does require a referral that can come from any doctor. So you could ask an ALS doctor, you could ask a primary care doctor. I think it's worth asking your ALS doctor, because there may be a palliative care team that they work with frequently and that they feel comfortable working with and that has more experience with people with ALS. Certainly at UCSF, our palliative care team works frequently with the ALS team, and we have a really, good open lines of communication. whereas a primary care doctor in the community may refer to a palliative care team that they work with, but that doesn't have as much experience with people with ALS. And through our palliative care for ALS working group that has just started over the last couple of years, we're trying to really provide education to palliative care clinicians about, and hospice clinicians for that matter, about ALS to try to build up the people's knowledge base. Because I think there's some palliative care and hospice teams that know a lot about ALS, that have experience with it, and there's others that don't know as much. We're also putting together a directory of palliative care programs that have particular experience and knowledge of ALS, and that's going to be available on the ALS Association website to try to help people with this illness find their way to programs that really know about ALS.
Thank you.
Yeah.
I now invite Harry and Bonnie to share their experience with palliative care.
When I was first diagnosed, I had to be intubated, and then they did the tracheostomy, which helped a lot. But they also inserted a feeding tube, which I found to be very uncomfortable and not very helpful. So I had to take it out very shortly after. And I've been eating regularly pretty much ever since. So I think they should be more careful when they decide to insert the feeding tube right away. If it's not needed, like in my case, it wasn't needed. And it actually was very uncomfortable. And it leaked and made it a really unpleasant experience. So that's my comment as far as the feeding tube. I also have a question about transportation. We had, until we found our local group that provides transportation, we were having to pay a lot of money to get transported to the hospital for different reasons. And I wondered if there's any kind of resource available that would provide some kind of care, transportation care that would be available if we need it. Right now, we're fortunate because our local city provides a fairly low cost transportation service, but I wondered if there's anything else available.
Let me jump in, Harry. I'm going to talk a little bit about your palliative care journey. When the care model that Dr. Bischoff was showing you in her presentation, the second care model is really been Harry's ALS journey as far as his care and integrating the ALS neurology team along with his palliative care symptom management. As you can see here, he's on a ventilator. So we've already discussed some of the challenges of a patient who is on an invasive ventilation system with hospice care. Additionally, Harry's never really felt comfortable transitioning to hospice, not just because of the ventilation, but just his own beliefs and attitudes about that phase of care. So we really just tried to integrate both teams with a focus on attempting things that are going to enhance his quality of life, not really focusing so much on longevity, but because we focused on quality of life, I think it's really led to Harry's longevity. Nobody expected a prognosis lasting beyond a couple of years for Harry. And, we're 6 years into his diagnosis, and we're still managing care at home, largely because of the palliative care team at this point. We only meet with his ALS team at this point a couple times a year because he has all of the equipment. Monitoring is in his stage of ALS because of the respiratory onset. It's pretty much been end stage monitoring from the get-go for Harry. people with other types of onset have different journeys, but for Harry, a lot of the trials he doesn't qualify for. There's been a couple of medications that he's qualified to take, but a lot of the trials that you hear about, people in the end stages of ALS with respiratory symptoms already don't always qualify for those services. So for us, we found the greatest benefit was the ongoing palliative care with we meet with him a lot more frequently than we do his ALS team. Not that his ALS team is not important, it absolutely is. But integrating the two, I think, has really been the best solution to help us keep Harry at home over the last 6 years. Without that, I don't think that would be possible.
I'd like to add that the Dr. Bischoff has been a great reference and a resource. And every time we have a communication with her, she's very helpful, and I'm glad to have her.
Thanks, Harry. Very kind. Thanks, Bonnie.
Thank you so much for sharing, Bonnie and Harry. Are there any questions for Bonnie and Harry? And you can continue to add questions for any of our panelists in chat. All right, I would now like to invite Robert to share your experience with palliative care.
My wife, it was in her 4th year after she was diagnosed. One night she woke up and couldn't breathe, so I had paramedics take her to the hospital. Anyway, they tested her at the hospital. Her breathing had dropped, tremendous, her muscles weakness, and they put on oxygen. And after about a week in the hospital, we had a doctor come and talk to us, and she said, "I'm a palliative care doctor." I didn't know anything about palliative care at the time. And she told us that before my wife could go home, she would have to be on the palliative care or hospice. And so they recommend palliative care. And she explained all about palliative care at the time. So after that, a social worker talked to us, and they got with the social worker from my neurologist at the multidisciplinary clinic. And we use the same company for palliative care as we had for home health care. And we was able to keep our same physical therapy that my wife had for home health care and occupational therapy and respiratory therapy. We kept all 3 of those. They changed the nurse that was specialized in ALS. And we kept up. The physical therapy would come whenever we need them, and about once a month, if we don't need them, they would come every month to check in on us. We received physical therapy once a week, occupational therapy once a week. A chaplain would come once a month and sometimes twice a month or whenever we need them. And the social worker would check up on us at once a week, call to see how things was going. And the physical therapy will also help with the cost assist machine, because my wife would put on a trilogy because the BiPAC wasn't working. So they put on a trilogy. And so we would have the physical therapy, or the respiratory therapy would come often to check. And whenever we call, when my wife felt like she wasn't breathing enough, she would come in and set it. And any medication, she kept taking the same medication she was taking, the ALS, which is Resolol. She kept taking that. And any time she needs the medication, we just tell the nurse calls the doctor, and within 2 hours, we have it at our house. And any equipment we needed, they would get. My wife had a feeding tube, and she could not take the one feeding medicine they were giving, the Longevity. I know it was less expensive, but they had to get on a plant-based, which was very expensive. And palliative care took care of that. The company took care of that. We didn't have to pay for anything. So any medication we needed and anything we needed, we got at any time. And a nurse was coming at least twice a week And anytime we need them, we would just call and they would send someone out. So we had a very good experience with our palliative care company. And I suggest if you have a good home health care, see if they also have palliative care in case you need it. And that would be my advice if you don't not on palliative care already, to check with the current home health care center that you have and see if they do have palliative care. I was very happy with it, and I don't know how I would have made it without the palliative care team.
Really great. Thank you, Robert. Wonderful to hear. And I guess I wanted to circle back to that point I made briefly that there's sort of two main types of palliative care. One is in a clinic that might be provided in conjunction with the ALS team or in communication with the ALS team. And then there's also home-based palliative care programs that often are part of either home health company or a home hospice company that has started a palliative care program. Generally, the in-clinic palliative care has a little bit more of like a medical model, like more physician involvement, for example. If that's certainly how we practice at UCSF. When we frequently refer people to home health for physical therapy, occupational therapy, and a nurse to visit in the home when that's indicated. And then the home-based palliative care programs can be really wonderful because often they can see people more frequently, see them in their home, but sometimes don't have as much experience with ALS or as close of ties to the ALS team because they're really built out of home health companies or hospice companies. But there's sort of some differences, some unique strengths and weaknesses of each type of care. But in case you had questions about that, I just wanted to add a few words.
Thank you so much for that clarification, Dr. Bischoff.
I can add, I've talked to a couple of home care agencies, to have a backup for Harry's care in case there's a family emergency or something for me. And one of the things that I ask every single one of them is if they also provide hospice services, because if they're talking to me and they understand that he's on a ventilator and that he's receiving palliative care, they understand that transition point. Or at least, the ones that are willing to work with a ventilated patient. And some will be very upfront with me and say they don't provide those services. And I've found a couple here in the Bay Area that are comfortable with that. So for me, that was a real surprise that because I had heard from other people that if you were on a ventilator, that, it would be hard to find those kind of services. But I think that model is starting to change a little bit too, just because there are more people who are choosing to stay in their homes. So I just wanted to add that.
Thank you so much, Bonnie. I have a question for you and Harry and Robert. How did palliative care complement the services that you were receiving at your ALS clinic?
I think the having access to such great people like Dr. Bischoff and the rest of the team is pretty helpful. They're always willing to answer questions, and I had the same experience as Robert, where if you need to call, you can contact them pretty much anytime, and they're available for whatever questions we have.
My experience was that the doctor at the palliative care stayed in contact with the doctor at the neurologist, our neurologist. So they would always talk to each other if it was something that was neurological or something that they didn't have the answer to. So we had the experience of both. And unfortunately, it was during COVID time when we was on the palliative care, and we used a lot of Zoom call with doctors and from both the neurologist and the palliative care. Matter of fact, at one time, my wife, I had to do a little medical things on my wife's feeding tube. She had one of the long feeding tube, and one part of it was kind of corroded like, and they want to take it to the hospital and change it out. And he said, no, let's look at it. So I held the computer up and he looked at the tube and he told me, get a pair of scissors and I'll show you where to cut it. So he had me to go through it and I actually did it right there and fixed it and no problem. And so both doctors work together. So that's what I liked about the palliative care service that we have.
You
Great.
actually can qualify as Dr. Robert Lemons now.
Definitely.
That's what
And I'd
the
just
nurse
like to, I'd also like to add that Harry's primary care physician is outside the UCSF care system. And it's a doctor he's been treating with for over 30 years. He didn't feel comfortable naming a new primary care physician, but in a lot of ways, Harry's palliative team has kind of taken on that role. Harry has some other medical conditions that we also treat, and they're aware of that. And we do reach out to them for kind of short-term medical advice, or if we have questions about holistic care for Harry. Whereas the ALS team, I mean, their resources are stretched. So if I need a response time really quickly, I tend to reach out to palliative care first. I still communicate everything with Harry's neurologist and his team, especially his respiratory therapist. They're really integral. But palliative care really helps us kind of deal with non-emergent situations or situations like antibiotics so that Harry doesn't have to present to the emergency room. For Harry, every ER visit turns into an ICU visit, which means he's waiting a couple days for an ICU bed. And his goal is to not do that, of course, or to minimize how many times he has to. So his palliative care team is really important to us because we'll have discussions about whether or not it's appropriate for him to start antibiotics early before he needs any IVs. And I know Harry really appreciates that.
One thing I liked about the palliative care, they were very conscious of bed sores because my wife in the last about 8 months, she was bedridden most of the time, except about an hour or 2 hours to get up. And so he's very, very conscious about that and always check. And every day, either they have the aide to come to give her a bath, they have to report to the nurse what they see that day. And they'll come by, a nurse will come by and treat it, even if it's not time for her to come by. So I really like that you have access to the palliative care service at all times, 24 hours, even in the middle of the night, 3 o'clock in the morning.
I have a question for Dr. Bischoff. Would
Sure.
you describe this palliative care as an intro to hospice?
Good question. It can be like it can be a smooth transition into hospice, but on the other hand, there's some people that we see in palliative care who never want hospice. That's just not consistent with their goals. They're people who want to extend their life for as long as possible, pursue every treatment that might prolong their life. So they might want to go to the hospital even when they're at an advanced stage of the illness and they're just not interested in hospice. And we support people with those goals, as well as people who want to prioritize comfort more highly. So it can be kind of a pre-hospice and a smooth transition to hospice, but it can also be very distinct from hospice care.
We didn't even experience that program. We had long-term care in Florida. We had a long-term care, and that's where we got I received some help with, the occupational physical therapy for my wife, and caregiver help. But we went right into hospice when it went at one point in time, it was decided we need hospice.
Yep. And I
And
think
that's
that's
when
not uncommon.
Yeah.
A recent survey study we did, less than half of people with ALS receive palliative care alongside their ALS care. About 2/3 of people with ALS end up getting hospice care. So there's certainly plenty of people who never receive palliative care. but who still may find hospice care or be referred to hospice care at some point. And we're just trying to, palliative care is definitely a newer and growing specialty, and it's grew out of oncology. So we have more of a presence in the cancer center, for example, but we're trying to expand, awareness about how palliative care can be helpful for people with other serious illnesses. And I think we've got a lot of work to do to just get the word out about how we can be helpful for people with ALS and their loved ones. And we're also trying to do, add to the literature base in this area. So if anyone's interested in that, happy to say more, but we're trying to, do larger and high quality studies to further sort of understand the role of palliative care and who needs palliative care, who could benefit from palliative care and in what ways.
Thank you,
And I'd
Dr.
just like to add, we haven't really we focused on a lot of like symptom management, but I think the other important thing about a palliative care team is kind of the psychosocial aspect. I worked a lot with the social worker on Harry's team, as well as kind of reaching out to the registered nurse. They've both been huge support systems for me and Harry, but oftentimes, they'll kind of help me navigate the role of being a caregiver and kind of, coordinating care for somebody 24/7. It's intense. And, we've been doing it for 6 years now. And there's a lot of stuff that comes along with that. And they've been really great, especially as we've kind of continued into the latter stages of Harry's ALS progression, really supporting me as a caregiver, as his spouse, as a family member, and as this like medical lay person who's trying to, coordinate all this stuff.
That's our caregiver, Freya. She likes to participate.
There's a lot to say.
Thank you so much, Bonnie. I think that was such an important point to touch on as well. And I know that we are at time. I have one question remaining. For people who may not have direct access to palliative care at their local institution, are there any resources to be able to access this beyond their institution? And how do they go about navigating that?
Yeah. So people can be referred to a palliative care program that's associated with their health system, that may be tied to their ALS clinic, or that's outside their health system. So for example, the program that Robert described, that's a home-based palliative care program that's based out of a home health agency. There are such things in many communities. So certainly if there's not outpatient palliative care available to people with ALS at your health system, it's worth asking your doctors, your ALS doctor, your primary care doctor, or others, can you refer me to a home-based palliative care program that might be run by a home health agency, for example. And I'm sorry that there's not yet a robust registry of such programs, but we're trying to work on that. So we hope to have something on the ALS Association website in the coming months.
Thank you so much, Dr. Bischoff. And thank you so much to Robert, Harry, and Bonnie, and Dr. Bischoff for being here today and for helping to educate and increase awareness about how palliative care can be so important in improving the quality of life of people living with ALS, as well as for caregivers. I want to wrap by also sharing that AM ALS is here to provide any support in a non-medical capacity. If you are seeking support with navigating resources related to ALS, including support with transportation resources and grants, please feel free to reach out to us. I will put our email in chat, and our ALS support specialists would be honored to provide any support. Thank you all so very much for being here today, and we look forward to staying connected with you and supporting you along your journey. Take care, everybody.
Thank you.
Thank you.
Bye.
Special thank you to Harry, Bonnie, and Robert. And thank you, Aditi,
Thank you.
for the invitation.
Thank you all. Take care. Bye-bye.
Bye-bye.
Bye.